what we're going to talk about today. Today I'm going to start out with tumor lysis syndrome. All of our objectives for every onco-emergency I'm going to talk about are the same. First we're going to do is talk about pathophysiology, talk about the patients at risk, signs and symptoms, the monitoring parameters, and treatment. So basically we're going to go what it is, how we identify it, and what we do to treat it. That's what I'm going to do for each oncological emergency. Are you guys sad you missed my introduction?
Yeah.
I can start over. I'm just joking.
Super bummed.
Yeah, I know. Because I'm really like low-key person, so can't hear me billowing down the halls. So tumor lysis syndrome. Tumor lysis syndrome, now this definition is tough, so stick with me here for just a second. It's a lysis of the tumors. So this can happen spontaneously. I've never seen it happen spontaneously, but textbook says it can happen spontaneously, but almost always, like 99, don't take that number to the bank, but like 99% of the time, that is not a test number. Don't listen to that. But like 99% of the time, it is caused by our treatment. So what's going to happen is we are going to do an excellent job treating cancer. That's what we're going to do. We are going to crush it. And we are going to just treat their cancer so well that their tumor cells just are like, I give up, and apoptosis, right? But the problem is when we do a fabulous job on really bulky tumors or people who have high tumor burdens, and all of those cells start exploding at once, everything that was on the inside of the cell is now on the outside of the cell. So if we have patients and when we do that total body irradiation on lymphedema patients or on lymphoma patients, when we do really good chemotherapy, when things are just working well, whatever we're doing, if it kills those cancers at too fast of a rate, then we have too much burden of what was on the inside of the cell that's now floating around our vasculature. Does that make sense? So that's when this becomes an emergency. So once again, it can happen spontaneously. I've never seen it. It's possible. Textbook, it's possible. It's usually because we crush it. Any questions on what tumor lysis syndrome is? Surgery. So in surgery, sometimes we can get all of it. Sometimes we can't get all of it. And sometimes as we're slicing through it, depending on how they have to get it out, because sometimes they can't just extract a tumor. Sometimes if it's wrapped around something, they have to take it in pieces. So if we get enough of that death of the tumor cell during the surgery, we can see it a little bit. Good question. But not nearly as much as radiation chemotherapy. Good question. What other questions do you have? Why are you smiling?
I just feel
Okay, good to know. Mental note. I was like,
I would totally tell you.
okay, thanks. I had cilantro for lunch, so I'm like, sorry, what other questions about the slide? And I promise I'm staying focused from now on. Good? Tumor lysis syndrome. Oh, that was the cell blowing up. I got it. So these are the main things that we're going to talk about are these three things. The things that I care about the most with these exploded cells, number one is potassium. Intracellularly, you guys have got tons and tons of potassium, right? So if all my cells start blowing up, all of that potassium that was intercellular is now floating around my bloodstream. As you can imagine, not the best thing in the entire world. Number two thing we're going to talk about is all the phosphates that get released. So once again, tons of phosphate inside the cell. When it's released, we start having issues. And then uremic acid. So we've got all of our DNA strands, tons of it has that uremia, right? And so once that's outside, it bonds and forms uremic acid. So those are our three major things that we're going to be looking for, is our potassium, our phosphate, and because of phosphate, with its interaction with calcium, we're going to look at that, and then our uremic acid. All of those three things combine to kill your kidneys. So we really care about time, Gia. About time. Sorry, I can't even believe that. No, now you have to sit up front. Stay away from and all of that works for renal insufficiency. Oh my gosh. So, oh look, it blows up again. Okay, so once again, the higher the tumor burden, the more likely you are of having tumor lysis syndrome. This lymphoma patient right here, obviously if you saw this on a scan, we're going to do everything we can to prevent tumor lysis syndrome from happening. And we're going to talk about that a little bit as well. So if I've got a high tumor burden, if it grows really quickly, then it dies really quickly, usually with our treatments, right? If it's growing really fast, usually our treatments are really effective to kill it. So high tumor burden, high growth fraction, and if they're already renal compromised, then that means they're already at risk for not keeping up with the junk that's about ready to enter their bloodstream. So if our patients have any one of these three things and we're about to treat them and we suspect they may get Oncologic syndrome, the best thing we can do for them is to do preventative care. So as we talk about these things, we're going to talk about not only treatment, but also prevention, because prevention is the best thing you can do for tumor lysis syndrome. Once you have a patient in tumor lysis syndrome, things start getting hairy. So prevention is the key for this onc-emergency. And that's kind of different from a lot of the other onc-emergencies. Lots of times, like, yes, we do things to prevent sepsis. Yes, we do things to prevent some of the other ones. But this one, the best treatment we have is prevention. And we can prevent it. Well, we can do everything we can to prevent it. Any questions on this? So, unfortunately, as we're talking about, this is my dead part. This is that's how I'm an ICU nurse, watching people die every day. I'm like, oh, I'm fine. So, no heart and you're fine. Anyway, back to tumor. I got off key again. I'm staying on this time for realsies. So, tumor lysis syndrome, signs and symptoms. Unfortunately for tumor lysis syndrome, it's pretty asymptomatic until it's an emergency. Because if you think about our three electrolyte categories, right? What happens if your potassium is just starting to eke up? What are your signs and symptoms if you're at home? Nothing, right? Too much phosphate, which is binding to calcium. What happens? Signs and symptoms, you're at home and your calcium is just starting to drop. How about uremic acid? You're at home, you just are starting to creep up on uremic acid. What are your signs and symptoms? It's not until they become at critical levels that we start becoming symptomatic. So signs and symptoms for tumor lysis syndrome are not seen until later stages. That's the unfortunate thing with this. So unless you're specifically watching for it, it's pretty asymptomatic until it's an emergency situation. So once again, what is the best thing we can do for tumor lysis syndrome? Prevention. So if you suspect, right, if our rapidly dividing tumor cells, heavy tumor burden, or renal patients are getting treatments, the best thing we can do is frequent labs. Watch those things before they become critical. So we're not going to see a whole lot of signs and symptoms, but we are definitely going to look for them if we know that patients are at risk. Good? What questions do you have on signs and symptoms, which are fortunately pretty much nothing? Good. So we're going to start with hypercalcemia. I want you guys to tell me, hypercalcemia, what are the signs and symptoms you guys are going to see? Heart irregularities.
Some muscles twitching.
You can, maybe some, you can start seeing, not as frequently, but it is a possibility. Anxiety, yep, you can see that. Yeah, there we go. Animations, right? So 6 to 72 hours after treatment. So anywhere from almost immediately to 3 days later is when you're gonna see this. So just watch it. Anywhere pretty much then. And so this is where it gets hairy. Once again, hardly any signs and symptoms. What cancer patient that's receiving active treatments, depression, fatigue, muscle weakness? Oh, wait, tumor lysis, right? Tumor lysis syndrome was the first thing that popped into my mind when I thought about a cancer patient who had these symptoms, right? Bell sounds, nausea. Oh my goodness. I'm like, oh no, it's tumor lysis, right? You don't see it. It's not until these later stages where you start seeing issues, right? And so hopefully it's not these that bring it in. This is the thing that's going to kill you the fastest in tumor lysis syndrome, is your hypercalcemia. Other things are going to contribute to it, but the thing that's going to kill you fastest is hypercalcemia.
Kalemia.
Kalemia is exactly right. I'm sorry. Read what's on the board. Don't listen to me. No, hyperkalemia. There we go. I'm so sorry. You guys are right. I apologize. Hyperkalemia kill you the fastest because of your heart issues that you're going to have. Once again, almost not symptomatic until you've already got an issue with it. So what are we going to do to treat with this? Burp, burp. So what we're going to do, oh, we already switched. I'm sorry. We're talking about all the assessment first before I talk about treatment. So assessment next. Hyperuricemia. So this is a double whammy. Hyperuricemia is a double whammy. What's going to happen in your body is you're going to start developing, get that uremia. That's going to bind to form uremic acid. Now, when you think of uremic acid, what's the first thing that you guys think about? Gout, right? That's where we see it most commonly, right? So what are some signs and symptoms that you may start seeing with these patients? I'm so deaf. Speaking to my good ear.
Joints.
Joint pain, good job, absolutely. You might start experiencing joint pains and joint weakness, absolutely. But that's a lot of uremic acid already. But that may be one thing that you see, or those little crystals. So we have that joint pain because of the little crystals. Guess what's worse than the joint pain with those little crystals? Your kidneys. Those crystals will start depositing into the kidneys. They will kill your kidneys so fast. So you think our number one problem that's going to kill us first is? Hyperkalemia, right? Hyperkalemia is going to kill us first. What's the best thing that we can do to get rid of potassium? There's some treatments. I can give insulin and dextrose, right? But that's still in my system, right? We like to get it out of the system. But if your kidneys are shot from uremic crystals, then it potentiates the problem. This one isn't going to kill you as fast, but it will help the potassium kill you fast. If you get down on this, if you get that buildup of uremic acid and it shoots your kidneys, the only thing that we can really do is dialysis to save your life. So if we can control this, then we can start controlling the others. But this has to be in check. Potassium will kill you fastest, but if this is an influence in your kidneys, it will potentiate that potassium to kill you even faster. Because it's going to kill your kidneys pretty darn quickly. Walk in the park tumor lysis syndrome, right? I've had worse. So, excess phosphate. I'm just doing this right. There we go. That's what I want. So, excess phosphate. Oh no, too much phosphate. Who cares, right? I don't care. If I have too much phosphate in my system, I don't care, except for one thing. It binds to calcium. Phosphate binds to calcium. So the more phosphate I have in my body, the less calcium I'm going to see. Ionized calcium, that free calcium, because now it's all bound. So now I have like basically no calcium going on in my body. So calcium binds to phosphate, renal failure. So once again, as it starts potentiating, when you have bound calcium, also really, really hard on the kidneys. So not only do I have low calcium, but the calcium phosphate bound, when it's bound, it will also kill your kidneys pretty darn quickly. So the only way to get it out is being stopped up even more. We've just turned that bloodstream going through the kidneys into a sludgy little river that's clogging everything up. Tumor lysis syndrome. What questions do you have about this? So hypocalcemia is the thing that we're going to see. This is the most symptomatic out of all of the three things that are going to happen: the high potassium, the uremic acid, and the phosphate. This is the most symptomatic thing we're going to start seeing. So if you have low calcium, what do you see? Muscle problems. What kind of muscle problems do you have? Twitching, right? Twitching. Their muscles are going to be super tight. Doing this, it's kind of addicting when they have it. It's like, right? It's spasms. I probably do that assessment a little too much when I have that with my patient. Oh yeah, it's still there. Oh wait. Yeah, it's still there. No. I got it. I kind of like it, watching it. So yeah, you're gonna start seeing those muscles be really, really tight. That's probably, like I said, the most symptomatic thing that you're going to see. And you can also start having heart issues. Your potassium is going to kill you with your heart, and then the hypocalcemia is going to help that out as well. What questions do you have about your hyperphosphatemia? Prevention is the key. Prevention is the key. One of the very first things that we're going to do is protect those darn kidneys, right? Because if my kidneys can function, I can urinate off my potassium, I can get out my phosphate, right? I can regulate things. So the very first thing that I'm going to do is I'm going to protect my kidneys. The thing that's going to kill my kidneys the most is that uremic acid. So once again, prevention is the best thing that you can do. So what I'm going to do, if I think my patient is going to have tumor lysis syndrome, I will start with allopurinol. Oh, animation. Ugh. Animation. Allopurinol and respiricase. Those medications I'm going to give to my patients. If I think tumor lysis syndrome, I'm going to do what I can to protect my kidney. If I can give allopurinol and respiricase in 2 different ways, it's going to stop that uremia from my DNA strands from becoming that crystallized acid that's going to kill my kidneys. So if you have a patient with a large tumor burden, a fast-growing tumor, or already has kidney issues, and you're about to give them a treatment that this is going to kill cancer, please pre-med them with this. And I'm sure a lot of you have already experienced pre-medding your patients with this. You give it to them a lot, right? Yep, you give it to them a lot. And this is why, is you're preventing kidney damage. Because if I can regulate my kidneys, I can regulate a lot of my other electrolytes. What questions on hyperuremia treatments? And next, hyperkalemia. Who does not, okay, so in a pinch, we're gonna get that potassium into the cell, right? In a pinch, that's what we're going to do. So if we start becoming emergent, the fastest thing that we can do to get that potassium out of the bloodstream is move it to a cell. So insulin and dextrose. Everyone good with, sometimes I forget, everyone good with that? Have you seen that on your units with your patients? This is what we do in a pinch. I see that potassium rising, I see heart starting to go whack with it, then I will get that quickly. That's the very fastest thing I can do. However, prevention, once again, is the key. So if I'm preventing things, I'm going to start them on loop diuretics, and I'm going to start them maybe on lactulose too, to get some of that out. Who's treated with lactulose? Who's had that pleasure? Yeah, who doesn't love that, right? So we're doing that to regulate that potassium that's coming out from the cells. Sodium bicarb, we can do these. We don't do these as much here because it messes with other things, but it will also interact with the potassium to get it out of the system. We just don't do it as much here, but no, it is a possible treatment. What questions do you have? Yes, so how we're going to manage our hypocalcemia. What is our hypocalcemia caused by? It's caused by our phosphates. So what I'm going to do to prevent those phosphates from binding to calcium is I'm going to give phosphate binding agents. So if I give them phosphate binding agents, calcium, Tums, sometimes does anyone ever feel silly giving a little Tums? You're like, here's your Tums, right? But thank heavens we have it, because that will bind to phosphate for us and regulate our calcium, right? Those Tums are important, dang it, right? So Tums, aluminium is actually what came to mind. Whatever the American pronunciation is, that's what we're going to give to bind to phosphates to regulate our more dangerous calcium effects.
So is that supposed to be hypercalcemia or hypo?
It is supposed to be hyper. You are correct. Thank you. Cass, take note. We're working on this next week to make things better for you guys. She's got a steel trap up there.
No, mental note.
Good, thank you for catching that. It's hypo.
Well, yeah.
Yeah, it's hypo.
Okay.
Yeah, I totally, because I was thinking Tums. It's hypo, because the phosphate bound to it. Yeah. It's fine, everything's fine. But I confuse everyone.
You're being recorded.
Phosphate binds to calcium, therefore causing hypocalcemia. By giving Tums, I'm giving calcium, and by giving aluminium, I am binding phosphate to increase the ionized calcium in the body.
Okay, so the note should say hypo, not hyper. Okay.
So if ever you need to understand what I just said. Are we on the same page?
Yes.
And tumor lysis syndrome, what's your phosphate?
It's high.
What is your ionized calcium? Low. Yes. Got it. Got it. Good? Okay, I'm so sorry about that. So renal protection. Once again, prevention is the key. I'm gonna do everything I can to prevent it. Very often we'll give mannitol if it starts getting to those critical stages. I'm gonna do whatever I can to boost those kidneys. Once again, as long as my kidneys stay healthy, I can start excreting some of those potentially problematic things, right? As long as uremic acid doesn't form, as long as it doesn't form to uremic acid, I can excrete that, right? As long as my phosphate, even if it's bound to one of the medications I gave, I can excrete that. Potassium I can excrete. The second my kidney gets behind, everything, like, it's like, you know those graphs, what is it? Exponentially, man, that's it. Exponentially, like, it just will get bad. Dialysis. There have been patients, and because this happens in such a short amount of time, right? We gave that time limit for potassium, but that's pretty much it for all of these issues. That 3-day mark. You can go asymptomatic, 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 and we have had patients, and it's usually when they're admitted to outside hospitals first that this happens, but they'll be admitted to outside hospitals. Usually they're good at catching them, especially here in the Valley, but we cannot get them to our ICU and on dialysis fast enough. If we hear that we're getting a tumor lysis patient from an outside hospital, we put that dialysis machine outside their door. We have what we need to get them a Shiley at the bedside. So when they come in, it is honestly a race against the clock. Sometimes we win, and unfortunately, very infrequently, but it happens, we lose. That we just cannot get that filtered off fast enough. Because once their kidneys are gone and they start getting those critical levels, the only thing we can do is get that off through dialysis. We have it all outside the door, and like we have it down if we know they're coming in from the outside hospital. And it's just, if we don't pre-medicate, if we don't have that, if we're not watching them and they go those 2 to 3 days and become critical, it is a race against the clock to get them on dialysis. So once, if our prevention does not work and they have to come in here, there are other measures that we have to do. We'll be giving those same medications, but good chance they'll be on dialysis to help out those injured kidneys. I hate it when we lose that kid. It's always scary when we get a report that we're getting one of those from an outside hospital. What questions do you guys have? Anything tumor lysis syndrome? All right, on that note, spinal cord compression. This one also kind of difficult to explain what it is. What happens is there's compression of the spinal cord. I can explain it again in a different way. Compression of the spinal cord. My objectives, imagine this, we're gonna find out signs and symptoms, pathophysiology, risk factors, diagnosis, and interventions. It's the exact same objectives for this one. So, when you get spinal cord compression of the spinal cord, just in case, you can have direct tumor involvement. This is super rare. It's super rare for one of those neurological tumors to actually be the primary cause of this, but it can happen much more frequently than sporadic tumor lysis syndrome, I'll tell you that much. But it can happen, still very, very rare, that it's a primary tumor. Almost always it is a metastasis. It can be either a metastasis to the spinal cord, which is more rare than like a bony metastasis, or even a soft metastasis in the same region that's just causing compression. So the three things: primary, bony, soft tumor, or a direct metastasis. But hardly ever happens. It's almost always metastases. So what's going to happen is this happens quickly, and the reason being is you can have these slow tumors that are slowly pushing on there, usually metastases, that are slowly causing compression, right? But the second that your cord gets irritated, what happens? If you irritate that tissue enough, what happens? Inflammation, right? So then you get inflammation to that area. And what does that do to the spinal cord? Compresses it. So now the spinal cord is even more compressed, so the tissue is even more damaged. So what happens with damaged tissue?
More inflammation.
More inflammation, right? So once that gets to that point that it starts sending out those inflammatory markers, I have seen patients come in with some of the early stages of spinal cord compression and not be able to walk by the end of my shift. So this can happen really, really, really quickly. Thank heavens for us, it's usually not in one shift. That's very rare for that to happen. But once it potentiates that negative feedback loop of inflammation, then you can see it progress extremely rapidly. spinal cord compression, extremely rapid. So once again, you can have the primary, the metastasis to the cord or to the bone, and this one is the most common right here. Oh, I didn't highlight it. So lymphoma though, lymphoma number 1, breast and lung number 2 for those. So lymphoma, breast and lung. And as we talk about oncological emergencies, if you ever have to, I can't say this on the test. I don't know, I can't say anything about the test. But I can talk about oncological emergencies. And the 3, if you have to ever guess the most common causes of oncological emergencies, just guess. Wait for you. Just guess lymphoma, breast, and lung. If you're gonna have to guess. But I'll tell you, for positive, for spinal cord compression, it is lymphoma, breast, and lung. Are the 3 most common types, or the 3 most common causes of spinal cord compression. So depends on, okay, so prognosis. I've seen patients make a full recovery, and thank heavens I see a lot of patients make a full recovery. I've also seen patients who have had lifetime effects. So depending on how damaged their cord is, and for the amount of time that it's damaged, and for their amount of time to get better, depends on their prognosis. So prognosis completely depends. That's it. Yeah, that's it. Right? I wish I could be more specific. But how damaged it was, for how long it was damaged, and then how long they have to get better, and their ability to get better. Because some of our patients will do palliative measures to help them with spinal cord compression, but if we're doing palliative measures, they're not going to be really great at regenerating nerve endings, right? So, or nerves in general, because those take forever, even in healthy patients. So prognosis completely depends on those factors right there. And signs and symptoms that you're going to see, imagine that. If you have cervical spinal cord compression, where are you going to see signs and symptoms? Everywhere below that, right? Most commonly, where do you see areas affected by the cervical spine? Head and shoulders, good. Head, shoulders, knees, and toes. Mostly just head and shoulders, though, not as much knees and toes. No, so head and shoulders, right down the arms is what you're going to see. Thoracic, what kinds of signs and symptoms are you guys going to see? Or where will you see them?
That theoretically could go all the way down, right?
What's that?
Can't that theoretically go all the way down?
It can go all the way down. You'll commonly see from here down, right? Thoracic. And if you start seeing lumbar spine, what are you going to see? Legs, right? You can see bowel, bladder, and legs is where you might start seeing these. Out of those 3, where's the most common place to see spinal cord compression? Thoracic. Why thoracic? What are the 3 most common causes? Breast and lungs, right? Breast and lungs. So where are you going to see the bony mets most of the time? Right there, that thoracic spine, right? So if you just, if you just think about the causes, then obviously you know where the most common is right there. So we see it mostly in the thoracic because of its causes. So this is one of my favorite oncological emergencies because so much about oncological emergencies and cancer and medicine in general is so like, well, you could have this or you could have this, right? Let me tell you right now, the number 1 sign and symptom that you will see in spinal cord compression is back pain. The number 1. That is the first thing that's going to happen is you're going to have pain. How many of you have back pain right this second? Right? So how on earth am I going to catch spinal cord compression in the pain stage? New, if it's new. If it's new back pain, I'm going to start interrogating my patient about their back pain. How else am I going to find it in the pain stage? I have chronic back pain. I injured it when I was 14 years old. I'm never going to have new back pain. But if I get spinal cord compression, what might that pain be for me? Maybe it's different, right? So, I mean, my patients complain of back pain all the time. But when they say, hey, oh, my back really hurts, I say, oh, is this different than it's ever been? Is this something new for you? If it isn't new, is this something different? And I ask those questions because I want to catch this in the pain stage. So is this new pain? Is this different pain? What else would be different about this pain than maybe some of the back pain that you guys all have now? Numbness, tingling, right? Is it a different kind, right? If it's nerve pain, so start guiding them towards those nerve pain questions instead of maybe some of those other questions, right? What else? If I have pain that's compressing my spinal cord, what other symptoms might I see with that spinal cord pain? It can radiate, right? It can radiate, right? Is it tracing down, right? And I had a patient once and they had a cervical one and it only hurt kind of under their arm. Right? Because that was the one it was affecting, was the underarm nerves. They didn't tell me for a long time. I had to interrogate them a lot because who has underarm pain, right? My arms really hurt. But the way that I knew to ask that question is because they're pillows, and when I asked them to pick up their cup, they were kind of like, they wouldn't put any pressure on that at all, and we moved their pillows to do something, and they're like, give me my pillows back, and I was like, oh, is it uncomfortable? And that's when they're finally like, it hurts under there. So different kind of pain or where it would radiate. So number one is pain. That is the first thing that your patients will have. Unfortunately, almost all your patients have back pain, right? But if it's something new, something different, if it's a different kind, if it's radiating, anything like that, you're going to get. The number two thing that they're going to have is motor weakness, and it will progress down this chain. So if they have back pain, the very next symptom that they will experience is motor weakness. How many of your patients have motor weakness at baseline? Right? Once again, not the easiest one to catch. One time I caught it because my patient, I gave her the pills to take and she went to reach for her water and she knocked it over. And I was like, oh, that's fine, you know, like I got that. So I cleaned that up, got her some new water. She went to take her pills and she's like, she couldn't like quite bring it to her mouth. And I was like, I had you yesterday, like what's going on? And so that's when, and I watched her try and reach for things and she wasn't just quite functioning the way I thought she was. And so that's when I questioned her more about back pain. We knew she had spine meds, and so we were able to look into that a little bit more. So catching those little motor weakness things, right? If they've walked fine every single day, if they're walking into your clinic and you notice them like dragging their feet, or if they like trip over their foot or something like that, that could be some motor weakness. So motor weakness. The number three thing that they're going to have is sensory loss. So pain, motor weakness, sensory loss. You'll see some of the same things with that, and then you're going to see motor loss, and then you're going to see autonomic dysfunction, and it follows that progression. We never did that in medicine, do we? But it will directly follow that progression. Pain, motor weakness, sensory loss, motor loss, autonomic dysfunction. That's what you're going to see with your patients. Number one, oh, I already spoiled my pain one. Another thing you're going to see is straining, coughing, and neck flexion. So you think about, you guys are all good with like neurological ones, right? When their ICP increases, you're going to see those same kind of things with this back pain. It hurts to tuck their chin. It hurts when you increase their ICP because it's all connected down that cerebrospinal fluid, right? So you're going to see some of those same things with this pain. The motor weakness, the sensory loss will all depend on the location of the bony met that we already talked about. So it be at least a little familiar. It was the T1 for the underarm. Isn't that crazy? It was T1. Crazy that she started having that pain. Late signs and symptoms is when you get to that autonomic dysfunction. They may wet the bed. Their breaths may be really, really shallow. And maybe you don't see them as much, but one thing that's going to happen, especially with their breathing thoracically with autonomic dysfunction, because they still have the drive to breathe because of the upper functioning of the brain, one thing you're going to notice is that they're not breathing deep enough. They're going to be breathing quickly because they're not getting the oxygen, but their breaths will be ineffective. So you start seeing shallow breaths. If you're using your IS on inpatient, you're going to start seeing them take in lower volumes than they have before. Outpatient, you're going to see them just like they're going to just be short of breath standing up. They're not going to be able to catch their breath. And even though they're breathing enough, their pulse oxygens are going to be low because they're very ineffective. You're going to start seeing confusion because not only are they going to have low oxygen, but they're going to start having an increase in CO2 because that's being trapped in the lungs. So you're going to start seeing those different things with your patients as well. So lower, you're going to get, of course, what we see, hypoactive bowel sound, sexual input, whatever that word is, and then like change of bowels and stuff like that. With the thoracic things, you will start seeing shallow breaths, ineffective stuff like that. Questions on this, on the progression? So we have to identify this. The sooner we can identify the problem, the better we can treat it. So scans are going to be your thing, right? You guys are all very familiar. X-rays, both scans, MRI, CT, PET scans, trace the nerves. That's what we're going to do. We hardly ever trace the nerves because usually we can see it on a scan. But it's very possible that these guys are going to get scans. The lady who had the underarm weakness, we knew she had some bony mets, but we didn't think that they were that much of a problem. They did send her down to CT to see if they, like, how far it progressed. So we will start seeing these different scans done. We love the MRI because it gives us the clearest picture of the invasion into the spine. So if I have to choose one and I can choose, I will choose MRI. Most commonly we give CT first because that's what we do to patients, huh? CT, oh, that will do MRI. But if you can choose MRI. It'll give you the clearest picture. Yes, so the number one answer, very, very important for oncological emergencies besides tumor lysis syndrome, what am I going to do to save my patient's life in an oncological emergency? Nope.
Treat
Nope.
the underlying
Treat the
cause.
underlying cause is the answer. Treat the underlying cause. So if I have bony mets or any kind of mets or even a primary tumor in the spine, what am I going to do to save my patient from spinal cord compression? I'm going to deal with the tumor, right? I've got to treat those mets or that primary tumor. I have to treat them. So I will do radiation. I will do chemotherapy. What am I going to do in the meantime so that it doesn't progress any further? Steroids, good job. I have to get them steroids while they're getting treated for those metastases, right? So radiation therapy, very, very, very common in these patients because once again, this is an emergency. It can progress really rapidly. This is one of the fastest things I can do to shrink a tumor. So if I can identify that tumor, shrink it quickly, there's a good chance they're gonna get radiation to make sure that they don't progress any further. Some things that they can do, both short-term and long-term, is they might have to relieve that pressure and they can actually do surgery, remove part or all even of their bone to relieve some of that pressure. So they can do those different things to immediately relieve that pressure. So if this is becoming life-threatening, especially lower cervical, upper thoracic, where it's starting to affect your vital organs, they can go in, do an immediate emergency surgery and immediately relieve that pressure in conjunction with steroids to get the inflammation down. We don't see this as much. In fact, I hardly ever see it, but it is something that you could do to save the patient. Pharmacological, we talked about steroids. They're key. If I have a patient with spinal cord compression, they will be on steroids because of that negative feedback loop. I'm gonna do everything I can with that tumor, but I have to decrease that inflammation that's being put out by the damaged tissue. So they will be on steroids. And then, of course, at the same time, you have to treat the underlying cause. They will be in a ton of pain, right? They're going to be in pain. Yeah, greater than 95% of patients who have this have pain. Those who don't, just because they lost sensation, I swear, right? They have that pain. That is the number one sign, so make sure that you're giving them pain medication. Depending on the location, you could be giving them anticonvulsants as well. Once again, it is an enclosed system. Your cerebral spinal fluid from your brain to your back. This can cause an increased ICP. So you might be giving them anticonvulsants and then obviously don't feel great, antidepressants. The best thing you can do for this is obviously prevent it, early detection. Luckily we have detection here, stabilize the spine, help them with ADLs. It seems counterintuitive, but the more they get up, the more they use that, the less they lose. So they feel weak, they're obviously fall hazards, but get them up. They're in pain, give them pain meds, get them up. If they can stabilize themselves, if they can keep up their muscles and their bones and keep those nerves stimulated, they're going to have a better prognosis for recovery. Seems counterintuitive when they can't walk that you want them to, but that's what you need to get them to do. What questions do you have with this? Spinal cord compression.
I have a question, actually.
Yes.
So if it's not in the brain, it's just in the spinal cord, they still give anticonvulsants?
Yes.
That's normal.
It's an enclosed system.
So seizures happen with spinal cord?
It can, because if you have an occlusion downstream, it can cause increased ICP.
Cool, good to know.
Yeah. They may do it. I've only really seen anticonvulsants with some of the higher spinal cord compressions. Yeah, because usually if it's lower, then it does more to compensate. It has more space to compensate. But if you put a little dam right up here, then you're gonna have that reservoir increase.
Thank you.
Good question. Any other questions about spinal cord compression? I love Cass's story about spinal cord compression, just to bring it home.
You want me to tell it?
Yeah.
Okay. We had a patient, I worked inpatient BMT, and we had a young patient come in with multiple myeloma, brand new diagnosis out of the ED. He'd been diagnosed because he had gone to like lots of different pain doctors, same exact thing, had like this really weird back pain, was becoming more and more debilitating, and finally his wife, like over the span of I don't know how much time, but she noticed that he had actually shrunk. He had lost like a foot in his height.
Literally a foot!
So one day she said, you know what, you're actually a lot shorter than you used to be. And that was alarming, of course. So his pain was so bad one night that they went to the emergency department. He was diagnosed with multiple myeloma because he had all of these spinal lesions that had basically compressed down his spine. He had lost that height. So crazy story, but he got admitted to the hospital with spinal cord compression, had a lot of defects from that, and he had a lot of like loss of mobility. And it lasted for quite a while. We didn't know if he'd ever regain his function, but it did start with back pain and a loss of a foot in his height. But it was kind of scary. Like he was in the ICU at some points and was like in a wheelchair for a long time. He was only like 26 or so.
So young.
Which this doesn't happen a lot of times with young people. Multiple myeloma is usually like old men. But so it was kind of a weird thing. But he used a cane for a while and a walker, and now he's like totally good. Has 2 kids. Because of fertility preservation. But he's doing really well. Like
Nicest guy, nicest family.
They were able to catch it, but it easily could have not gone that way, you know, especially with like such an extensive amount of spinal lesions.
Take home there. It's crazy. You see crazy stuff. Increased ICP. This one also difficult to explain. The pressure in your cranium is increased. That's the definition of this one. So increased ICP. Once again, my objections are the same. So you've got 80% brain, 10% blood, 10% fluids. If you have an increase in any one of those 3 things, something has to give, right? So tell me, looking at this, thinking about your patients, what are some different things that would cause fluctuations in these 3 things? Tumor, obviously tumor, right? We work in cancer hospital, tumor, not only primary, which happens more than anything else that we've talked about so far, but also lots of mets go to the brain because of the high blood flow to the brain, right? So we can have tumor in the soft tissue. What else happens to your patient that would cause an increased ICP? They hit their head, right? How many platelets do all of your guys' patients have? Right? They hit their head, they have a huge chance of a brain bleed. That's one of the fastest changes in ICPs, because if you get a bleed in there, it is no longer 10% blood, right? You just had a huge influx to that area. What else can you guys see?
When we give the chemo, sometimes it brings.
Absolutely, right? Are you guys ever going to do it when a doctor asks you to inject something intrathecally?
No.
Nope, don't do it. Don't do it. Please don't ever do that. And don't do it, right? Yeah, so intrathecally, we could just introduce something in there that's not even in that 100% and make it 110%, right? So we're not gonna do that. We're gonna let the doctors do that. They get paid way more than we do, and do not get paid enough to do that. What else might you see?
Crannies,
What's that?
craniotomies.
So for the treatment, we can definitely start seeing that. Those are fun. I love cranies. We're gonna talk about those. They're fun. What else? There are different things that can happen with cerebral spinal fluid too. I've actually seen tumors that produce CF, whatever the letters are, cerebral spinal fluid. I've seen tumors that produce that. And so they came in with massive headaches, and it was because they had, whatever I just said. Is it late for anyone else? Yeah, who have got tumors that actually produce increased cerebral spinal fluid. So their cerebral spinal fluid has been off the charts. Another thing that happens is when we get some of those blood, like leukemias and stuff like that, when they have higher counts in that area, it draws fluid, right? That's why mannitol is our drug to help with this, but it can draw fluid to that area as well. You can get edema. Septic patients who have tons of brain mets. You think about cancer, and cancer is really, really vascular, right? Really vascular. If you get a septic patient, what happens to all of your vasculature? What's that? It dilates. When you get septic, all of your vasculature dilates. If you have mets in your brain that are highly, highly vascularized, what's going to happen pretty darn quickly? You get so much cerebral edema in there, right? Because those highly vascularized tumors are now all vasodilated, and you get tons of leakage into the brain. So you can even see something like sepsis increase their ICP. So our patients very, very susceptible to increased ICP. One or more of these components increase in size. Good, causes, we just did it. Okay, so something has to give. I've got this skull, and it is like measured out to perfection. I have to have 80% brain. Let's be honest, some probably have less. 80% brain, 10% blood, 10% cerebral spinal fluid, right? So I have this perfect harmonious balance inside this nice encapsulated skull, and as long as it stays that way, we're fine. However, once one of those things goes out of whack and increases pressure, something has to give. And this is where we start seeing, we have our nice empty ventricles that are full of cerebral spinal fluid. That's one of the first things that we'll see is we'll start seeing a deviation in those ventricles. It's one of the very first things it's going to give. So you might see, and you'll hear on reports, as a shift. They've got a right shift or a left shift. What signs and symptoms are you going to see with a right shift or a left shift in your assessment?
Somnolence.
What's that?
Somnolence. Sleep.
So you'll see a change in level of consciousness. You can see that. What else are you going to see? You can start seeing some stroke-like symptoms. You can. Hopefully it doesn't get to that, but absolutely you can. What else? One of the very first changes. You guys know?
Unequal pupils.
Good job, that's it. Anoscoria, you're gonna start seeing anoscoria, where your pupils are not the same size. You guys think that you're shining the light in there? Do you guys still do that? I hope you all do it. Hope you all do your thorough assessment. Shining your light in there, you're gonna start seeing deviations, usually only in almost always in one side. And you'll start seeing it be a little more sluggish. Because that comes all the way from the back, all the way to the front. So if you get any compression anywhere in between, you'll start seeing pupillary changes. So anoscoria is something that you'll see in increased ICP. One of the first things that you're going to see, as well as changes in level of consciousness. Imagine one of the very first things you see is they get drowsy. Cancer patients getting drowsy. I think ICP. So you'll get herniation here. Then anywhere where you have space, you're going to herniate. Most dangerously, the biggest hole that we have in our head, some people for me think it's this, it's not. It's down the back, right? It's down the back of the skull right down there. Unfortunately, if we start getting herniation or shift in that, what's in the back of our brain right here? The brainstem. What does the brainstem control? Everything, including breathing, heart. It controls a lot of that autonomic stuff, right? So if we start seeing pressure build back there, you start seeing a ton of vital sign changes, and that's very, very, very bad and negative and dangerous and deadly. You start seeing that, you're in a bad place for your patients. Oh, I have this, I don't even have to go fly there anymore. Right? So, number one causes. Right? Breast and lung, that's what you got. It's not even on here, I'm sorry. But leukemias, bleeding disorders, tumors, bleeding into the tumors, once again, because they're so highly vascularized, that you have that increased potential for that. You can get obstructions of CSF. That's why we were talking about spinal cord compression right here. If I start getting blockages, you get that increase of cerebral spinal fluid. So that can also cause going in there, SADH, some of these other things that Cass is going to talk about. Early symptoms, imagine this, headaches. Cancer patients, headaches, right? But these headaches will be characteristically different than some of the other ones that they're going to get after they just got done throwing up or after they just had a sleepless night in the hospital, right? This will be something different. It will be worse when they cough. It will be worse when they look down. There are different aggravating factors will make it worse. Valsalva maneuvers, really, really horrendous. Stool softeners, absolutely the key. Absolutely the key with that. If you suspect increased ICP, make sure you are giving them stool softeners, regulating their bowels. You walk in over to NC, who's floated to neuro care? Anyone floated over there? They are hardcore about their bowel regimens. Hardcore, because you guys think about how hard it is to push down, to bear down, and so that we're going to prevent that with that. Neurological disorders, you're going to start seeing visual changes and level of consciousness. Gastrointestinal, imagine that, they're not hungry. What? They're nauseated. ICP nausea, I'm not sure if you guys have seen someone with an increased ICP vomit. Man, it is violent. There's something a little bit different about ICP vomit than there is about regular vomit. I mean, you get really horrible vomiting with some of those different chemos, but ICP, it is very violent. And it's horrible because what does vomiting do to your ICP? Oh boy, right? So very important to keep up on some of those. Late symptoms, unfortunately, decreased level of consciousness. This is when you start seeing posturing, which I have never seen. Respiratory, you start seeing, oh, there we go. So then you start seeing our vital organs. Talking about abnormal posturing, I really hope you guys never see it. It actually makes me sick to my stomach when I see it. But if you have someone who starts posturing, what are the different posturing that they may have? Right, so you have that, decelerate, and what else do you have? Decorticate. Which one are you gonna see first? Cord. It's gonna go in first, so you're gonna like try and keep hold of yourself first, right? And then you just kind of give up and push it all out. That's kind of how I remember it. So you'll have decorticate first and then decelerate. And I hate those. It literally makes me sick to my stomach when I see that. It's so unnatural to see like you pinch someone and then they go, I don't like it. I really don't like it. Hopefully you never see that. And hopefully you never see some of these later things, but it does happen. Seizures are one of the very first later signs that you may see, unfortunately, along with pupillary changes. Do your pupillary assessments, man. And if you suspect ICP, then do them more frequently. When you walk into the room, do that. Sometimes I used to be really mean. I thought if I saw pupillary changes or if I was worried about ICP, even if it was 2 o'clock in the morning on a night shift, I would go in and flip on their lights and like look at them, you know, and like, because maybe I didn't always do that. But you know, they close their eyes. I'd be like, open your eyes, and I would see like if I could get that. They hated me. I loved them though, which is why I did it. You're gonna start seeing these different things. Very, very late sign that you're going to see is Cushing triads. Abnormal respiration. This is an important one to know. I see this all the time. Very important to know. This is a late sign, but abnormal respirations, widening pulse pressure. What do I mean by this? Right, the systolic is going to start getting higher and the diastolic is going to start getting lower. So when you start seeing that spread, that's widening pulse pressure. So abnormal respirations, widening pulse pressure, and bradycardia. You guys see this, you're in a world of hurt. Your patient is in a world of hurt if you start seeing this. We had a patient come in for a GI bleed, and the nurse was so great. He came in for a GI bleed. So he had a little bit of level of consciousness change, right? As you would expect. He's a GI bleed. He's really hypovolemic. We're doing everything we can to catch up with that, right? But the nurse, the amazing, awesome nurse, while she was doing her physical assessment, things didn't seem right. Pupils were a little off and a little sluggish, but he was also really somnolent and his electrolytes were off, right? But started seeing that and she's like, I really don't feel good about this. He was complaining of a headache, but he was complaining of a GI bleed and he was extremely dehydrated. How do you guys feel when you're dehydrated, right? And so the nurse went and told the doctors and was like, I really don't feel good about this. I think something may be going on. She didn't pinpoint it right at that moment, but in her full assessment, she's like, I think there's something else going on here besides the GI bleed. Some of the things I found in my assessment just aren't fitting that GI bleed picture. And unfortunately, they kind of blew her off a little bit. Unfortunately, anyway, but but she felt in her gut that something was wrong. And so she actually kept almost continuously assessing this patient. I mean, they weren't doing good anyway with their GI bleed, but she kept assessing them. And she started seeing some of these things. They were really tachypnic at first. She saw the tachypnea. When she saw the tachypnea, and when she in a hypovolemic patient, you should see the pressures go down together, right? But she saw that diastolic dropping way faster than the systolic, and that's when she put it together. She's like, wait, he's breathing 30 and kind of sporadically, and he has that widening pulse pressure. He was a little more tachycardic still. Why? Yeah, he was still a little hypovolemic. His cord hadn't quite been affected to that point yet that it wasn't taking away that hypovolemic compensation. But when she saw those two things, she's like, oh my gosh, this guy has an increased ICP. And she saw that, man, she caught it. She caught it so early. And she told the practitioners, it only took her like after her initial assessment, I think it was the next hour or an hour and a half, 90 minutes. And she was like, this guy has an increased ICP. And she went and she told the practitioners and they're like, no, he doesn't. And they're like, and she's like, yes, I do. And she came in and like grabbed me and was like, this guy has an increased ICP. And so like we did the assessment. We have this nice little pupilometer. You guys should come and use it sometime. If you think your patient has pupillary changes and you're not sure, call to the ICU and say, hey, can you just bring down the pupilometer really quickly? Super fun. It's this point and shoot little video camera that it will flash into their eye, and it video records the reaction of the pupil, and it actually gives you numbers for its size and how quickly it responded. Absolutely love it. It's the coolest thing ever. So we got the pupilometer and we did it, and there was anoscoria, very, very noted anoscoria. And so we went to him and said, anoscoria, right? And we said, 2 out of the 3 of Cushing's triad, right? And so finally they ordered a CT, massive, massive shift. He almost didn't even have a right ventricle anymore in his brain, completely massive. His tumor had totally taken over the right side of his head. And she caught that because she knew what to look for with ICP. And she had to even fight for it, which was a little sad. But when you know these things, you can start recognizing them. You can save lives. We didn't save lives, obviously. But you can save lives otherwise. I promise. I promise. I don't need to look at the computer. So, surgery, life-threatening. We got those cranie patients. What they do for a craniotomy is they will literally drill into the skull, cut out a piece of the skull, and let the brain expand so that it has space to expand. Sometimes they keep it right close. Lots of times they'll just do a little incision in the abdomen, put the skull in there so it stays gets the nutrients that it needs, and then like when they're gonna close back up, they'll take it out of the abdomen and put it on their brain. Isn't that crazy? Love it, love it. So they might get that, and then, yep. So surgery is going to give you immediately relief and do that. Hyperventilation. This is actually fallen out of favor, but hyperventilation is going to do what to my CO2?
No.
What's going to happen to my CO2? Right, if I'm breathing 30, 40 breaths a minute, CO2. I'm going to breathe off all that CO2. Do you know what CO2 does for vasculature? So what CO2 does typically is it's going to vasodilate. CO2 vasodilates. If I breathe off my CO2, what's going to happen to my vasculature? Vasoconstricts. So what happens to the percentage of blood in my head? It should go down. So in a pinch, if I need to like quickly decrease ICP, I can drop it a point or two maybe by decreasing the amount of CO2 in the body, which will thus cause vasoconstriction, which will decrease the percentage of blood in the brain. Is that a good long-term effect? No, why? Why don't you want to do that for a long period of time? I can't on a ventilator, man. I can crank them up, and I do. I'm just joking. Right? Why isn't that a long-term solution? They have to be ventilated, and I have to get blood to my brain. I need oxygen, right? So I have to get blood up there. In a pinch, if they're going to die, I can do that, maybe drop it a couple points. It has fallen out of favor, but once again, in a pinch, it might be something that you could do to relieve a little bit of that for a second, until you can do some other interventions. Radiation therapy. Imagine that. What am I going to do to save my patient who has increased ICP, this oncological emergency? Treat the underlying cause, right? So if it is a soft tumor, I'm gonna make sure that I get that down. Radiation therapy, gonna get it the quickest thing that I can do to hit it, in addition to some of the, like adjunct, some of the other things I'm going to do, chemotherapy. Obviously steroids is a good thing to do, right? Because as soon as my brain tissue gets irritated, what happens? Swelling, right? And the more swelling I have in my brain, the more tissue is irritated, and the more tissue that's irritated, the more the swell, right? So they usually almost are on corticosteroids. Osmotherapy. Mannitol is our number one for our diuretics to decrease. It is very common for us in an oncological emergency of ICP to administer large amounts of mannitol. If you've never done that, lucky you. It's the worst thing in the entire world. You have to pull it up through a filter needle. Why? Anyone know? Has anyone ever worked with mannitol? It crystallizes. When does it crystallize? Do you guys know? When it gets colder. At room temperature. It crystallizes at room temperature. We have to store it in a heater. So you have to have a heater, and then you pull it out, and it's starting to get to room temperature. So you have to use your filter needle, and you usually have to we use the 60 ml syringes. So I'm like trying to pull that out, right? Like, through a filter needle. This guy's like dying right here. I'm like, okay, hold on a second. Right? And then I like pull this out, right? And then I finally get enough after like 4 bottles to get the dose that I needed, right? Don't take out the other 3 bottles, because they're gonna crystallize. So I got like, and then I get it, and then I'm like trying to get it in the IV. Mannitol, it's fun to administer, but that's one of our number 1 things because it does work directly in the brain, in the cranium, to isolate decreasing ICP. And then anticonvulsants, we will work with the fluid as well. What questions do you have about interventions so far?
LPs that increase.
Right, if we can get off some of that. So depending on the cause, then we could do that. In an emergent situation, we don't. But if I know that the cause of their ICP is like one of those random tumors that makes cerebrospinal fluid, then we may put in a lumbar drain. So we might not only tap their spine, but we may leave a drain there. Those are the worst things in the entire world. It's a gravity drain. So what happens if you stand up and that drain is open?
Oh.
Yep, you guys got it. That's what happens, right? So if we have those patients that we can do a cerebral drain, we can do a drain in their ventricle, in their head. We call that something that I'm sure is coming up. What do we call that? An EVD, an extraventricular drain, or we've done lumbar drains. And the number 1 thing that you have to know about that is, can your patient move? No. If you're going to reposition your patient, what are you going to do to the drain? Clamp it. Yep, you got it. Good. Did that answer your question? What other questions do you have about treatment so far?
So they don't usually shunt those internally? That's
If it's going to be, they can do that palliatively, like if that's going to be a forever thing, they can do it. They're going to try and treat the underlying cause, but if it's palliative, I've seen them do it. Good question. What else? Here we go. We are going to do, you as a nurse, everything that you can to minimize ICP, which includes bowel regimens, nausea medication, lights, TV, sound, their significant other. Joke, guys.
No
Single
jokes.
awareness day tomorrow.
No jokes. No laughing.
It's actually the day that Arizona became a state tomorrow. So my sister and my roommates, all of us are from Arizona, are going to get Navajo tacos. I'm excited. Anywho, I did eat it again, dang it. So, what else are you guys gonna do to decrease ICP?
Keep their head up.
Head up, right? Don't you dare lay them down. Head up, what else are you gonna do? Your cares, you're gonna be going in every 2 minutes with new things. What are you gonna do? Yep, consolidate, cluster your cares. You're only gonna be in there as minimally as possible, right? If this patient has diarrhea, what are you gonna do? You gave it to them with their bowel regiment. What are you gonna do?
Tell them not to push.
It's leaking out by this point. Go work on
Probably
that.
give them a rectal too, like how.
Rectal tubes are great. Rectal tubes are great for these patients. Absolutely. Really, really great. If your nurse needs to go, or if your aide needs to go in and do vital signs, what are you guys gonna do?
Go with them.
You're gonna go with them to do your assessment at the exact same time, right? You're gonna coordinate cares with your CNAs, HCAs, to make MAs, to make sure that you're doing clustering your care, so you're not bugging them as much. Passive turning, head of bed, proper alignment. If you have patients that are losing level of consciousness, don't do this, right? What does that do? Right? Keep it straight, so we got a good drainage system. Don't let them be scratched, don't let them be like that. Make sure that they've got that nice straight line, so hopefully your spine can absorb some of that impact. What questions do you guys have about increased ICP? We totally do. But you know what the bad thing about increased ICP is? What is one of the first signs and symptoms of increased ICP? Confusion, yeah, neurological changes, right? So is the neurological change being caused by increased ICP, or is it by the fentanyl you just gave them? Which one is it? We don't know. They're very stingy with pain meds. They're very stingy with pain meds on these patients. Sad but true. And you would think they're thrashing around, right? What does that do to your ICP? But if you give them Ativan, was the confusion caused by the Ativan, or is your ICP increasing? It's the worst. Don't work in neuro. We just stole a nurse from the neuro ICU. She would not like this part of the lecture. I'm sorry, Robin!
Just a question, frontal nurse, do you still use the screws?
The bolts? Like that screws into the skull?
Yeah.
Yeah,
You do.
yep. To measure the ICP, absolutely. Yep, they still use them.
Barbaric.
What's that?
Barbaric, correct.
Yes. It's minimal payment. We got something. They get, yeah, Tylenol. Tylenol, they're fine. What other questions do you have? Cardiac tamponade. Who doesn't love a little tamponade, right? To explain this one, your cardiac is tamponade. I'm just joking. I'm just joking. The objectives. So we've got our heart right here. We got our nice heart. We've got that sac around our heart that gives us a little bit of lubrication and support for our nice beating heart. However, it can only hold so many fluids, right? And incorrect grammar, I apologize for those of you who love English as much as I do. So, you've got your heart, you've got your pericardial sac, and a mouse cursor. Just happens to be in there most of the time. And what's going to happen is this sac is going to get filled with fluid to the point that your heart can no longer function. What is the difference, riddle me this, between pericardial effusion and pericardial tamponade?
The pressure?
Resulting effect of the effusion.
You got it, the resulting effect on the heart. It has nothing to do with timing, it has nothing to do with volume. In a pericardial effusion, there's too much volume in your pericardial sac, but your heart can compensate. In a pericardial tamponade, there's too much fluid in your pericardial sac, but your heart can no longer compensate. That's the difference. And the difference between a pericardial effusion and a tamponade, they call it the last drop phenomenon. Just that last little drop that makes it so that your heart can no longer compensate and can't keep up with it anymore. So that's what happens in a pericardial tamponade. So you can have tumor evasion, you can have sclerosis of the pericardial sac because of radiation. You can have, what else do we have here? Oh, pathophysiology, we just talked about it. Ultimately, you lose the amount of blood that's being able to pump out of the heart. Why is that? It can't expand, right? Well, what will your heart rate be? It'll probably be high, right? Because I don't have any cardiac output, so that will be high. My heart rate will be high, right? But what's being pumped out? What about the volume that's available to come into the heart? Is there enough volume? Heck yes, there is. All of that volume is going right, but can it go through the pump? Can't go through the pump. So thinking about that, skipping ahead just a little because I like you guys and want to quiz you. If I have that happening in my heart, what are you guys going to see on your nursing assessment? Jugular vein dissection. Good. What else are you gonna see or hear? You're gonna see edema. Why crackles? Tell me about crackles. Am I going to hear crackles in the lungs? What are crackles caused by? Fluid. Is there fluid getting to my lungs?
Oh, no.
Not much fluid getting to my lungs. If I had normal left-sided heart problems, then I would definitely see that backup of fluids. However, do I have anything coming into even my right side? No, so maybe not usually crackles.
Muffled heart sound?
Muffled. Yeah, muffled heart sounds. I think it's so funny when they say muffled heart sounds, because when I have a patient with a pericardial tamponade, I'm always like, do you hear those muffled heart sounds? And I'm always like, because I can't hear anything half the time. Like, I can almost never hear heart sounds in pericardial tamponade. Maybe because I am deaf in this ear a little bit, but it's really hard to hear heart sounds in pericardial tamponade. What else was your physical assessment?
Maybe breathing faster.
They are going to be breathing faster. Why is that?
They're not getting oxygen.
No perfusion. Your cells are starving.
So your heart rate's gonna be the same?
Heart rate
How
will
about
be,
low? Because the heart cannot.
the heart can't pump, but that's the muscular part, right? What is the electrical part? Your SA node. It's firing fast, right? Because the things that stimulate my SA node to fire are being stimulated, right? My baroreceptors, right? Different things are being stimulated, and they're saying, hey, we're not getting perfused. And the SA node is like, leave it to me. Right? But what's happening? Why not? It can't expand, right? It can't expand. For those of you taking my EKG class, one of the most severe cases I've seen of this, we had a patient admitted in. We knew she had a pericardial tamponade. That's why she was admitted to our ICU. I was talking to her and she passed out. What did I see on the EKG? Right? I saw that SA node going, right? But what happened when I felt for her pulse? Why no pulse? There's no squeezing, right? PEA, pulseless electrical activity, and we had decoder, right? So you're gonna see that she has that pulse. It's just the muscles can't respond, right? So she's got JVD, she's got edema, she's got muffled, I didn't hear heart sounds, let's be honest, but muffled for textbook, muffled or distant heart sounds is textbook. I didn't hear anything.
So when you code somebody with cardiac tamponade, how do you actually get some space? Yeah, because you can.
Well, if someone's coding, what do? If it's oncological emergency? Treat the underlying cause. What saved that patient's life? Those practitioners came in, everyone knew exactly why she was coding. They grabbed the ultrasound, grabbed the 14-gauge angiocath, attached it to a 60 cc, and she woke up. One of the very few patients I've ever saved in PEA, if not the only. Yep, treat the underlying cause. So, early symptoms, chest pain, muffled heart sounds, weakness. Imagine your patient is a little anxious, dyspnea, right? They feel like they can't breathe. Why do they feel like they can't breathe? They're not moving oxygen. There's no chemical exchange, right? There's no chemical exchange. Coughs and hiccups are one of the first symptoms and one of the most common symptoms you're going to see. Why do you see coughs and hiccups in pericardial tamponade? Irritation of, do you remember what it is? The phrenic nerve. You guys are so smart. The phrenic nerve. Irritation of the phrenic nerve. The phrenic nerve runs right down the side of the heart, and that's what stimulates your diaphragm. So if that's irritated, it's going to cause hyperstimulation of your diaphragm, leading to coughs and hiccups. Good job. You guys are so smart. I would not know this. It also amazes me. When I teach classes, I feel so dumb. Phrenic nerve. I'm like, right? So it's going to feel tight in the chest and all these different things. Late signs, narrowing pulse pressure. What does that mean? Closer, those numbers are going to get very close together. Their mapped, their systolic and diastolic are almost all going to be the same number. Yes, you're going to see a drop in systolic, but your diastolic will raise. Your mapped, diastolic, systolic are all going to be about the same number. A late sign. Pulsus paradoxus, what does that mean? Do you guys know? This one is really hard and you're not going to get a whole lot of experience with it. because you see it mostly with continuous blood pressure monitoring, like an art line. However, you can see it with a cuff pressure if you know what you're looking for. So what's going to happen is I have my blood pressure, right? And that's being regulated by the squeeze of my heart. Good? What happens if I take a nice deep breath in? What happens? Right. I got my lungs filled. What does that do to my pericardial sac? Compresses my pericardial sac with those inflated lungs. So what does that do to my blood pressure? It drops it. Yep. So I see when I have my art line in, I have a nice waveform that's showing me it's systolic on the top of the wave and they're diastolic on the bottom. And I will see that drop with their breathing. That's pulsus paradoxus. Once again, really hard to see with the cuff, but if you know what you're looking for, you can have your patient, when you know about the numbers where they are, you can have the patient take a deep breath and you will hear that systolic drop, like you'll lose it. So if I'm doing a manual blood pressure and I hear that their systolic is at 100, and I say, okay, take a deep breath, you will hear that systolic drop. You'll lose the systolic. So that's what you can hear with a cuff on pulsus paradoxus. Altered level of consciousness to urea, obviously. So Beck's triad, another triad, because we can't ever escape the triads, right, in medicine. So what you're going to have is an elevated CVP. What's a CVP? Central venous pressure. What does that measure? Do you remember? That is measuring the fluid available to enter into the right side of the heart. So you guys aren't going to have a central line that's going to give me a CVP. So what's a rough thing that you guys could do to know that you have an elevated central venous pressure? Jugular vein distension. If you got jugular vein distension, then your CVP is high. Yep, that's what I look for when I don't have a CVP in. Hypotension. What's going to be hypotensive? Which number? Systolic. My systolic number will be hypotensive. Good. And then distant or muffled heart sounds is the textbook. Once again, who hears that? I can't hear them. Right? That's what I'm going to see in Beck's triad. Beck's triad is tamponade. Beck's triad, you're looking for CVP. You're looking for that narrowing pulse pressure, that hypotension with your systolic, and then distant heart sounds. How you're going to see this? On a chest x-ray, you will see this massive heart. Maybe. This is where it gets a little crazy. How much fluid do you need to cause a pericardial tamponade? Do you guys know the minimum? If it is a rapid infusion, you can have it with as much as 300 to 500 mils. Isn't that crazy? A styrofoam cup of water can cause it. If it's rapid. Why only if it's rapid usually? Your heart can't compensate. It was a huge shock and it can't compensate. So that can cause tamponade. Here's another crazy fact. You can get up to almost 2 liters before you tamponade in a slow infusion. Can you imagine picking up that 2 liter from the store and just sticking that in your chest? Sometimes you won't tamponade until almost 2 liters if it is a slow effusion. Why only a slow effusion? Your heart compensates and it gets used to that horrible environment. Crazy, huh? So anywhere from 300 to 500 mils to 2 liters, your heart can handle before you tamponade.
How do you correct the sac? It's stretched out to 2 liters.
Rough, huh?
Yeah.
Does your heart need the pericardial sac to function? It doesn't need the pericardial sac. So on my lady who coded, I don't remember how much we pulled off. I wish I did. It didn't matter. We would have pulled off everything that we could have to get a pulse. And I don't care that the pericardial sac was enlarged or anything. I needed the heart to have relief to function. So maybe it wasn't as supported as it could have been. Maybe it wasn't the safest, but I needed it to fill and then to give me that pulse. So we pulled off, I know it was more than 60 because I know that they emptied it and went again. So I don't remember how much we pulled off. I know they did it quite a few times, but I didn't count. I was doing other stuff. Good question. Good. So in a chest x-ray, you may see a ginormous heart like this. Sometimes it's only slightly bigger, depending on if it's rapid or slow. CT, you're going to see the masses. Echo is the funnest thing in the entire world to watch on a pericardial tamponade. It's so cool because what you're going to see is you're going to have that echo right there. And normally you have the heart that's supported by the pericardial sac. But now the pericardial sac is huge. So you just created a swimming pool for your heart. So what's going to happen to that heart if it's in a swimming pool trying to beat? It swings, it moves. And you see it sitting there swinging and moving in your pericardial sac. You actually can see it. It's crazy to watch on an echo, but you see it like swaying and moving with its musculature in its new grip, big huge swimming pool. That's what you see in an echo. I love it. And because you have your EKG stickers on, one right here, one right here, one right here, two right here, right? They're in a set place. What is your EKG going to look like if it's trying to hit a moving target? Are the lines just straight? No, the lines will start swimming. And because you're having different, like your electrical system is working, but with it swimming, you're gonna start seeing changes in your EKG velocity, because sometimes it's closer and it seems like, whoa, that was really strong. So you have like a huge velocity, but then when it's away, it's like, oh, that was super weak. It doesn't know that it was actually weak because it was farther away. So you'll see changes in your QRS voltages. Does that make sense? So you'll start seeing those EKG changes. Your lines won't be straight and your QRS voltages will change because sometimes it's close and it seems strong. Sometimes it seems weak, but it's really just far away. So that's what you'll start seeing. Pericardiocentesis, we're going to talk about a little bit more. So treatment. So treatment. What am I going to do if my patient has this oncological emergency of pericardial tamponade? Treat the underlying cause is the number one answer, except they're dying. So what am I going to do before I do that? Just pull it off, right? I'm going to pull it off. Over 50% of oncology cancer patients, that was redundant, over 50% of oncology patients will get a pericardial tamponade again if they've already had one, or fusion. Over 50% will get an effusion again. Why? Right. My lady who coded, I had immediate results with that pericardiocentesis, but did I solve anything? What caused her pericardial tamponade? Cancer. She had lymphoma, and it had blocked the ability for the pericardial sac to empty. Yes, we saved her life in that second, but is she going to get a pericardial effusion again? Absolutely 100%, because we did not treat the underlying cause at that time. Obviously, we saved her life, right? But we didn't treat it at the time. In order for her to not get that again, we had to treat the underlying cause. If you don't treat the underlying cause in a cancer patient, it will come back. Now, when I did trauma ICU, it was different. I had car accidents come in all the time with the seatbelt or the steering wheel on their chest, right? That immediate trauma caused a pericardial tamponade. We tapped it, and they were fine afterwards, right? Because there was no more seatbelt or steering wheel hitting their chest. So, like, that was easy. We're like, all right, just tap that and we're done, right? But in cancer, what causes this? Cancer, right? We have tumors around that area. We have lymphoma, so it can't empty. We have scarring because of radiation or chemotherapy, right? What's one of our most common chemos that causes that? Doxorubicin, right? So we are giving things that are actually hurting the heart, right? So we have those different things that are causing it. So our cancer patients, if they get it once, chances are they're going to get it again. Over 50% of them do. So we have different interventions that we can do. First thing we're going to do is alleviate the symptom, right? So very, very common for these guys to get a tap at the very minimum. To get a tap. Then we have to do what we need to do, chemotherapy, radiation, to treat the underlying cause. If it's not going to work, or if this is going to be a long-term thing before we can fix the underlying cause, we're going to try a couple of different options. One thing we can try is pericardial sclerosis. This is a little painful for your patients, but we will give them or inject chemotherapy directly into the pericardial sac that causes it to completely sclerose so that no fluid can accumulate. So hopefully it just goes in and pushes out. Yeah. It usually takes more than one treatment for that to happen, and it does cause actual sclerosis of the pericardial sac. You can see that as a palliative measure. Another thing that you're going to see, oh, look, number one causes. What? What? Corticosteroids, yes, it is a treatment. I don't see this one as much as some of the other ones, but corticosteroids can help. In the meantime, these are what they're injecting. Leo is the one that I've seen the most. Leo, minocycline. Pericardial window is something that they'll do. So if it's a patient, this is going to happen for quite a bit before I can actually get rid of the underlying cause. They will go in and cut a little window in the pericardial sac so that that extra fluid goes down into the pleural space and then is reabsorbed back into the body. So if it's unable to be reabsorbed in the pericardial sac, they'll put it in the pleural space so that it can be reabsorbed there. So pericardial window.
When do they do just a drain? So we had a patient with the pericardial drain.
I like those. Yeah.
That.
What's your question?
Just when do we do that instead of the window? If it's more temporary? Or?
I don't know. Just what's going to be best for the patient. I don't know. I wish I could tell you. Good question. I'll look it up for you. I honestly, like whatever's gonna work best. Some patients, maybe they'll get better. And so if I put in a little window, one of the cool ways that they're doing windows now is they actually go to cath lab, use the cath lab, stick a little catheter through the membrane and then blow up a balloon. So then they blow up the balloon, create a window, but then they can suture that back together. So maybe I'll do that if it's gonna be like, hey, we think this will be gone in maybe a year or two, and I don't wanna deal with a drain for a year, right? So I can go get that window and then it can be better. Maybe that's one.
Well, our guy didn't have to drink very long.
Yeah, I mean, I wouldn't want to drain for very long. What kind of drain do you have, just out of curiosity?
I don't know the name of it, so it goes drains very often.
I've seen some that are just Pleurix drains, that they hook them back up to like Pleurix.
I think we had a patient.
Yeah, I've seen gravity drain, yeah, whatever you said, I've seen. In drastic cases, one thing that they can do is just take off the pericardial sac. If they're gonna die, and this is gonna keep happening, take off the pericardial sac. That way they're not gonna get a pericardial effusion. It will just straight into the pleural space, and at least they can still live the rest of their life without having a tamponade. You can see that as well. Radiation is just causing the sclerosis as well instead of the injection. I don't see that one as much because it's hard to target just the sac without getting the heart itself. So all possibilities. So what am I going to do for these patients? Nursing interventions. Conserve energy. Good. What I want you guys to think about is, instead of pericardial tamponade, thinking about the structure, what is the thing that's making my patient sick in pericardial tamponade? The heartbeat, right? I don't have cardiac output. So if you have a patient with a low cardiac output, what are your interventions? Oxygen. I want them to have oxygen. I'm good with 100% on these guys, right? Why am I good with 100% oxygen on these guys? They're not perfusing. Whatever can eke out of that compressed heart, I want it to be fully saturated so it can deliver, right? So I'm gonna give them oxygen. Good. What else? Someone with low cardiac output, what are my interventions?
Don't work them up.
What's that?
Don't work them up.
Don't, yeah. These patients, very rare, I'm not going to be getting them up and walking. For me, but, right? I'm not going to get them up and walk while they're like this. What did you say?
Body positioning.
Body positioning. A lot of times these patients like to lean forward a little bit. Very commonly with these patients, they like to sit at the edge of the bed, have their bedside table and lean forward because that brings the heart forward and gives them a little relief of some of the pressure of laying back. So they like to lean forward. What else? Your patient with a poor cardiac output.
Output.
Anxiety, I am going to give them anxiety pills. You're exactly right because they do feel anxious. What'd you say?
Output.
Output. Yep, I'm going to look at that. If I've got huge swelling here, JVD, what am I going to do? Lasix, I am. I'm going to relieve some of the pressure on the heart of it coming in. Seems a little counterintuitive because nothing's coming out, but if you have a ton of pressure building up on that heart, it's not good for the heart either. So you may see acutely, maybe a little diuretics. Not much, but you might see a little. What else? They're going to be on EKGs? They better be. They better be, right? Is the teletech going to call you when they code?
No,
No, they're not. Good. They're not going to call you when they code. Yeah, so you guys got to assess these guys. You guys have to know, right? Edema, systematic, eyes and nose, good. Oxygen, good. Good. That's what we're going to do. How do you guys feel about pericardial tamponade? Superior vena cava syndrome. This is superior vena cava. So what happens is I have my nice superior vena cava right here that dumps in all the blood from what part of my body? The top part, my arms, my head, the upper part of my chest. All of that blood will dump in via the vena cava. Through the superior vena cava. How about the inferior vena cava? What blood is that? Everything from down below, right? From here down is the inferior vena cava. Superior vena cava is about here up, right? What happens in superior vena cava syndrome is either you have a primary mass, extremely rare, you have metastases, also kind of rare, or you have tumors that are just located in that area, very common, that compress that superior vena cava. We can even have it from the central line that we put in. If there's a clot around that, then it's going to block the ability of the blood to empty down through those upper systems. And so you can get superior vena cava syndrome, meaning for one of those reasons, the blood from up here cannot dump into that superior vena cava. That's what's happening. Thrombus. Talk about that. Thrombus. Street chapter talks about it. Direct tumor wall invasion. Yep. Got it. Okay, good. Just making sure. So what am I going to do to treat this? Treat the underlying cause. What are some things that you're going to see in your patient? Yes. Massive swelling here, massive swelling here. In the arms, you're going to see that horrible, horrible swelling in the arms, right? How about your cardiac output? How's that? Cardiac output is down. Is it as horrible as pericardial tamponade? No, because I still got that nice inferior vena cava, right? For those of us who have large derrieres and bottom halves, right? I still got lots of blood emptying in through there, right? So I still got an okay, but I will start seeing some of that fluctuation in hemodynamic stuff. Prognosis completely depends on what's going on, what's causing it. One of my most memorable patients who had SBC is he had a tumor, a primary tumor that had just eroded and grown in there. There was nothing we could do about it. So I just watched him over time until his family and he decided that it was time. Just watched him get puffier and puffier and puffier. Watch this. So it completely depends on what the cause is for how well they do. So imagine this. Oh my goodness. Lung cancer is number 1. Why is lung cancer number 1? The area, right? Lymphoma. Why lymphoma? You got it. Blocking that area. Excellent. Pacemakers have actually been known to do this, as well as catheters and radiation, just causing stenosis of the superior vena cava. Not as common. Breast is also in the top 5 for this one too, just in case you wanted to know. So you're going to have that. We don't see these as much, but it can happen with the sclerosis and the occlusion. Early signs, facial swelling. You guys named them. Yeah, you got it. Dyspnea. Why on earth would you have dyspnea as one of the number 1 most common signs? Superior vena cava syndrome, dyspnea. Why? Swollen. You are so swollen in this area, right? What does your neck look like? Does it look like this beautiful, well-defined neck that you see here? What does it look like? It's swollen, right? It looks like this neck. That's what you see there, right? You got that swelling. It's compressing. It's compressing up here too. You have pressure in this area, so you're not getting as good of lung expansion. You definitely, dyspnea, number 1. Why is the cough non-productive? They're not wet, right? They're not wet. Your lungs aren't wet. Your airway isn't wet because are you getting enough blood to back up into the lungs? No, it's not even emptying into the heart, right? So you'll have a dry cough. You'll start getting cirrhosis because of all the pressure. Late signs, headache, visual disturbances. Horner's we're going to talk about in just a second. Dyspnea, stridor, CHF, all that because you're not getting any emptying in. Horner syndrome. Horner syndrome is going to be Horner syndrome. Horner syndrome. Horner syndrome. You're going to get unilateral eye swelling. Unilateral eye swelling. Constricted pupils, and you're not going to sweat. Horner syndrome. Unilateral swelling, constricted pupil, no sweat. That's what you're going to see. Plethora, they're going to look red. Why do they look red? The blood is backing up into your face. You've got so much blood supply backing up into your face, right? So there's the unilateral eye swelling, and here, look at the difference between this poor lady here. Nice defined neck, not defined neck. One thing you're going to see, I wish you could see it a little better up here, is you're gonna start seeing the vasculature. You can see some of the lines, maybe you guys can't, maybe you can in yours, but.
Spider webbing?
Yep, you get the spider webbing up here, because even the little vessels are beginning to fill up and get backed up. So you can start seeing a lot of that spider web up here in this area as well. Horner sign though, that's a good one. This is called Stokes sign, when the neck and face get like this. Stokes sign, and then Horner sign. Good. I'd say anything. We talked about this. You guys got it. We talked about that. So, diagnostic testing, they are going to get imaging. MRI is the preferred because you're going to see what the occlusion actually is, if it's eroded in, if it's just pushing on it, how big it is, what we need to do to treat it. So MRI is the #1 diagnostic thing. They can get lymph nodes done, sputum, stuff like that. It's really hard in the beginning, but until you see that defined swelling. So you're gonna see some of those other things. They almost always get scoped pretty darn quickly because they can image through that way too. So image and MRI, scope, a bronch and an MRI are done pretty darn quickly with that. I went the wrong direction. So pharmacological, what am I going to do pharmacologically to help these patients who have all this fluid backing up into their head? What's that? Diuretics, absolutely. Diuretics. That guy who had it forever, he was on our unit for almost 3 months. We gave him increasing doses of diuretics every single day, which was hard because this lower body still needed fluid. So I needed to drain that out to have him be able to speak. Corticosteroids, what's that going to do? Until I can treat that tumor, I have to decrease inflammation. Because as soon as that tumor causes tissue damage on the superior vena cava, what happens? Inflammation. Once inflammation happens, it causes more tissue damage, and what happens? I love our body system, right? It's trying its best. Bless its heart. Chemotherapy, radiation, obviously, to get, obviously to shrink the underlying cause. In the case that it is a clot, we will use TPA. I love it when it's a clot. And we just use TPA and we're done with it, right? Almost always though. Don't like it. Radiation we talked about. There are surgical options. I'm not going to talk about them. There are surgical options. We rarely do them. It involves massive heart surgery. It usually does not get done on cancer patients. Just know that it is a possibility. It is within the realms of options. But that's all I'm going to say about that. Remove the central line, remove the pacemaker, whatever you need, radiation chemotherapy to shrink that tumor. So, what are your nursing interventions? We talked a little bit about some of them. Before or after treatments, what are you guys going to do?
Oxygen.
Oxygen. Yep. Absolutely. Oxygen. What else? #1 thing I'm going to do is positioning, right? Am I ever going to put this guy's head down? Never. Never. That poor guy in 3 months never got to have his head down again. But he didn't want it down. Why not? Oh my goodness, so much pressure in his head. He sat straight up for the last 3 months of his life, right? Positioning, massive. What else? I had this one lady and she loved her sweatshirts, but I swear they were from the 80s because they had that elastic around here.
Love those.
What did I do? I cut it. Yeah, I did. I cut it. Why did I cut that? Right, I was not going to have that constriction, right? I tried to be nice. I cut a little hole and then cut out the elastic. I tried to be really nice, but wasn't letting that happen. Also, conservation of energy. You don't have to get these people up to walk as much until there's a little bit more treatment. That monitoring got it. Structural emergencies plus tumor lysis syndrome. What can I do to help you understand anything? Get that done. Thank you.
Thank you.